Good afternoon. This afternoon, I'm going to talk about another virus, which is virus. Arthropod is a vector, basically, of this virus. Insects, they are vectors for arthroviruses. And I chose this topic because it's going to be very close to your heart, because you have so many applications for Chikungunya virus in this island. And the good news is the fact that finally we do have a very effective vaccine for this virus. And all of you are eligible for this vaccine, which one I'm going to go over the recommendation of the CDC and advisory committee for immunization countries to tell you who is eligible for the newly approved vaccine. But before that, I was thinking that we go over some question um, for the future virus. I'm not going to answer them, but I thought this were the main thing that I try to discuss. The future virus is an old virus with no clinical and epidemiological features. What are the ecological, biological reasons behind the new outbreaks and the new clinical features? Because you remember the epidemic were very well known. It was in a certain number of the countries. The outbreaks were very small. The disease was not fatal, but new outbreaks are big in new environment, in new countries, and also the disease is very severe. Why and how these things or these new changes happen? The second question is four genotypes of Erythritol have been identified. Like dengue, you have four serotypes in dengue virus. This is also holds true with Erythritol. Is there any cross immunity among them? In another word, does infection between of the genotypes generate antibodies to protect against future infection by the other genotype? In dengue, you do not like to be infected with the second genotype. So if you are already infected with one genotype, that infection is going to make you susceptible to a very severe form of the dengue if you acquire the second genotype of dengue. Is this true for the future or is not true? What does make interruption writing Mitch's life cycle more difficult than interruption of the writing mosquito life cycle? And what is the evidence in support of neuroinvasive nature for a future virus? And finally, I want you to come to 5 reasons to explain this graph. The travelers coming back, different seasons to the United States, and this is a statistic of the future infection among them. But the overwhelming majority of them, they acquire the disease during the August. Do you have June, July, and August? Do you have any other explanation for this graph? Come to 5 reasons based on what you learn about the virus, about the ecosystem, about the vectors, to explain basically this graph. And this is just reminding you that only the female mosquitoes they bite and they need blood for the eggs. Now, let me focus on chikungunya virus and the disease. Uh, this is overview, very briefly, just to uh, put the content of the lecture, and then you know exactly what I'm going to be talking more in detail. It is singular stranded RNA virus, but this is positive sense RNA virus. You remember that Urupuche was negative sense RNA virus. This is the positive sense RNA virus. Transmitted by bite from infected Aedes mosquitoes. So it's only mosquitoes, but only mainly Aedes mosquito. A disease characterized by acute fever, inflammatory joint pain, often joint pain involvement is bilateral, it is symmetrical, it is severe, like rheumatoid arthritis rheumatic type. Many often, many of the physicians are mistaken rheumatoid arthritis with chronic phase of the uh, chikungunya. Incubation period is very short, and almost half a million cases and 190 deaths by November 8th, 2024 were reported, and majority of them happened in, in Latin America. Chikungunya is underreported because we do not have a good diagnostic test available to the communities, and also clinical manifestation of this virus is not very unique. There's so much of the overlap between this virus and other viruses in clinical manifestation. And we do have two cycles. We have two symbiotic cycle, and this is among the monkeys, also rodents, and birds, and mosquito. And again, the mosquito is very specific mosquito, these mosquitoes. And then obviously, a couple of human become infected when they go to the forest, and then they bring you to the rural area where the augmentation is going to happen. And finally, from rural area, the people move to cities, and then the inhabitants of the people in these cities are going to be infected, and the outbreak is going to. So let me now go over what I said a little in more depth. So this is one of the alphavirus, and this is the program ID, and is another strand RNA virus, this group. It was identified in 1950s in Africa, in the southern province of Tanganyika. The Tanganyika was only one country for a short period of time in 1960s, and then it joined Tanzania. So now it is a part of Tanzania, basically. And disease was given a local, basically name, Kimbokonde name, and chikungunya, and according to an educated local chief, the term was derived from a root verb of Chikungunya, meaning dry up, because the joints are so swollen, are so painful, the person is mobile, cannot really move around. It is basically bewitched. The person suddenly cannot walk, is frozen, so dry up. So this is the meaning of the chikungunya. And these are the Aedes aegypti, and we didn't have Aedes aegypti in the United States, but when we had the West Nile virus, this Aedes aegypti, in a matter of fact, traveled from Israel to New York through the obviously in one of the aeroplane, and then brought the West Nile virus to New York, and then it spread from there to east and the west part of United States. And then we have also these mosquitoes, and we call both of these mosquitoes zebra or tiger eggs because of the white spot that this mosquito has. So this tiger eggs. And it is Egyptian also is the vector of dengue, Zika, and chikungunya. And already you know that we need to add the future to also three of the more famous report viruses. We want also to introduce you to different types of mosquitoes because you are going to be familiar, you should be familiar with them. One is Culex. The Culex is mainly can basically transfer the West Nile virus as well, swine flu encephalitis, and West swine encephalitis. And you also need to be familiar with Anopheles mosquito, which is the carrier, and the vector, the malaria. Distinction between Anopheles and the rest of the mosquitoes is very easy because Anopheles lands vertically. So if you see a mosquito on the wall and this is this way, then obviously this way, then you know that this is Anopheles. But if it's Culex, then obviously it lands on the wall this way. So easy. Just look at the mosquito and the way that the mosquito basically is on the wall or any place on your skin and you can recognize the Anopheles. This is the life cycle of the virus. Already, is symbiotic cycle on canopies, the monkeys, birds, and the rodents. They are not really coming even down the trees. They usually finish and complete the cycle on top of canopies. Then gradually, as you can see, this is Aedes Platanus, then gradually adapted itself to the human and it became Aedes aegypti. So the ancestor of the Aedes aegypti obviously is Aedes Platanus. But over thousands of years, this mosquito larvae come down from canopy and then be inhabitant in floor of the forest and then obviously the rural area and later on receive an adopted itself to be very successfully in big cities. And this is the life cycle of the mosquito. All that I want you to know from eggs to hatching and becoming adult, it takes only 6 days. But now we have some evidence that in a matter of fact this is shrinking. Some of the mosquitoes they have learned to do everything very fast. Maybe 3 days of having water would be enough for them to put the eggs and the goes through larva, pupa, and then become adult. Usually the mosquito is staying in your territory. So if I have a mosquito at my home, this is not the mosquito of my neighbor. This mosquito is just has breed around my territory. And they usually are very good to identify a little at the water and then to live very successfully in that place. They do not travel. But sometimes the wind carries them completely away, and just the um, uh, on top of the Everest leaves spider. And then I don't want to go over the biology of this spider, how this spider is maintaining itself on 30,000 feet elevation with temperature, extremely cold. But the major question for the scientists was what this spider lives on. And it happened to the matter of fact is the wing brings the insects to the Everest. And then obviously this spider leaves on the insects brought to the Everest by the, by the wing. So we learned that it is primarily spread by the bite of infected Aedes species, but unfortunately vertical transmission may happen, and the vertical transmission is very common, but many often the virus gets to the baby in the uterus. Susceptibility of the uterus depends on the stage of the growth of the uterus. I'm sorry, of the embryo. And so the chance that the embryo will become infected is only 2.5%. But has significant consequences, obviously. And reservoirs are humans during epidemic and the monkeys, rodents, and birds during non-epidemic periods. What is the current situation with chikungunya epidemiology? To your left is the map of the activity of this virus before 2014. And to your right, obviously, is the activity of this virus after 2014. So you would see before 2014, it didn't reach to America. But then if you look in 2014, then you would see the virus finally cross the Atlantic Ocean and then finally got to the America. And then you would see main in Brazil, in the northern part of Latin America, then Central America, Caribbean, then obviously a part of the United States. And that we are projecting in a matter of fact, because we have seen that it is adapting itself in the colder temperature. We believe by 2050, this would be the area that the virus activity. You will see a part of the Europe now is going to be infested by the mosquitoes. And then obviously the virus finally is going to establish itself. I know that right now in some part of the Europe we have the mosquito cannot really maintain the virus, it's successful from one generation to another generation. But already the mosquitoes they have adapted themselves to the colder temperature, completely different environment, even in some parts of the Europe. And then obviously already we do have this group of the mosquitoes even implemented. So, you know, so they have moved from Florida. Now we have seen them in Connecticut, for instance. We've not yet established a niche for the virus. But vector now. Now, what we need to bring some of the patients that they do have the virus in their blood, put them in Connecticut, and the virus bites them. The virus is going to be infected, but now the virus needs to go through generation of the adaptation for the virus to complete its own cycle in the body of the mosquito. And then the virus can be transmitted to the human. So don't think when we have the vector, for instance, we have the virus, then we have the complete cycle of the virus. No, the virus has to go through adaptation in the body of the mosquitoes over maybe decades before the virus finally can be successfully stay in the body of the mosquito and be infectious in the body of the mosquito in a new environment. And the picture of the epidemic is different in different parts of the world. For instance, in Brazil, all the time we have a small outbreaks and then suddenly big outbreaks. But in some places like India, it is like endemic. It is all the time, 12 months a year, you do have some number of the cases in India. And these are the epidemiology in travelers. I do not know how much basically you're familiar with Sentinel group or Sentinel or Geo Sentinel sites. Those of you who are really much very interested in research doing on arthroviruses, I told you yesterday that CDC has a branch on arthropod viruses, which is not in Atlanta, I think is in Colorado, but CDC collaborates with International Traveler and Tropical Medicine Society, and they have put many travel clinics around the world for returning travelers. And when they come back with fever, they try to understand the nature of the disease in them. Is a way of the surveillance and immediately sending a warning, for instance, that there is a new virus is coming in this corner of the world. And this is
Geo Sentinel analysis from 2005 and 2020, almost 900 confirmed and 300 probable cases of the chikungunya. 89% their age was between 18 and 64. 59% of them, they're females, and 49% were tourists. 28% of them, they were uh, local people who went back home to visit family and basically relatives, and 14% happened among the businessmen. And overwhelming majority of these people, they are coming back from Caribbean. That's the reason I said it's very close to your heart, because overwhelming majority of the people with chikungunya that come back, for instance, to United States or get back to Europe or England, they are coming from Caribbean islands. And the major question is then why we do need protection against chikungunya. Obviously, epidemic is expanding. Diagnosis of the chikungunya is not easy. We do not have a very good, easy point of care test, for instance. The clinical picture is very non-specific. And also, it causes severe disease. And I will show you some literature that is neuroinvasive. It gives you myocarditis, and even up to 10% of the patient with chikungunya, they may die from the infection. Particularly, imagine somebody is 65, 75, and then gets this virus. I will show you why the people who are old already have comorbidities. They may die from the chikungunya virus. And the virus, we know much better about the interaction of the virus with the susceptible, basically, cell. And we do know the receptor of this virus. You can see GAG is one of them, for instance. There are several receptors and molecules on the surface of the human cell that would host the chikungunya virus. And then chikungunya virus, obviously, you will see easily, is going to inject the nucleus, inject the genetic information into the cytosol, into the cytoplasm of the cell, and then you will see that this is the positive double-stranded RNA virus. And then obviously you will see it goes through multiplication, transcription, very close to Golgi bodies, and then makes different compartment of the virus. And then is going to assembly is going to happen very close to the membrane of the infected cell. And finally, the virus is going to bud off. And now you are dealing with a new infectious virion that is going to find a new cell, a new susceptible cell to infect. There are four stages in, in this virus. So there is incubation period that already I told you is short. Is a few days, maybe 7, 8 days, but most often is about 4 or 5 days. So after incubation period, obviously, the mosquito was infected, injected the virus, and the virus now is going to be in the lymphatic system, goes to the circulation, goes to the cells, and then takes some time to proliferate and then becomes billions of the copies. And then you can see this is the viremia. So this is the level of the virus in the serum or the blood of the infected person. Then you will see it goes up, up, and now you're almost at the end of the first week or the beginning of the second week, and you have the highest concentration of the virus in blood. But meanwhile, you would see what was happening to the antibody, the defense of the body against this virus, and you will see IgM comes first, but disappears quick. But then IgG goes or comes next, and then is going to stay for a long period of time. And IgG obviously is going to neutralize the toxicity of the virus, and then you go through disease resolution. But when the person is viremic, obviously the patient is sick, and the patient has fever, myalgia, polyarthralgia, rash. I would give more info about clinical presentation of the chikungunya because I have seen several of them. But then, if after the resolution, then certain number of the patient, unfortunately, the virus is going to find itself a way to stay in the body. Later on, I'm going to talk a little more about basically how this virus is going to maintain itself in the body of certain number of the people that genetically most likely they are susceptible to the persistence of this virus in different part of the body, but mainly they come down, for instance, with arthritis, and the arthritis is closely mimics the rheumatoid arthritis. And this is the acute symptoms to the left of this slide. Meningoencephalitis has been reported. You would see involvement of the eye, conjunctivitis, uveitis, for instance, fever, splenomegaly, invasion of the liver and spleen, peripheral blood, and then a rash. I will show you certain number of the photos that shows the rash of this infection, but unfortunately, none of them are very specific. And then myalgia and lymphadenopathy, as well as the arthritis, swollen joints. And then uh, acute symptoms last for a short period of time, and the person is going to recover completely fully. But then, unfortunately, a few percent of them, you're going to come down with very, very severe form of consequences, like myocarditis, like hepatitis, nephritis, and then uh, neurological manifestation of the disease, and then increased risk of severe disease among neonates, particularly. Not is only vertically transmissible, but neonates, like very old people, they are extremely susceptible to the severe form of the infection. And 1 out of 4, which is 25% of the people, they are going to come down with chronic arthritis even 2 years after the original acute infection by this virus. All that you need to remember from this slide is the chronic phase of the infection, and that's arthritis. And somebody who's coming to the clinic, wait that you think the patient may have rheumatoid arthritis. If that person is coming from endemic area for chikungunya, please think of the chikungunya as well. And this is the rash. You would see it is maculopapular in one, then you can see hemorrhagic, petechial in the other one, and even urticarial in the third one. So clinical manifestation and skin manifestation is very diverse. And this is the time that the virus is in highest concentration in blood and is invading blood vessels. So when it invades blood vessels, so particularly is going to be very common, for instance. This is another basically person with uh, a rash, which is erythematous. It is petechial, it is maculopapular, and similarity between the rash of the chikungunya uh, and Zika virus and rickettsial species. So, based on the rash, there is no way that you can make the diagnosis of the chikungunya. So, the risk factor for severe form of the disease is age of more than 65. And this is not unique to this virus. Influenza, if you want to get influenza when you are 25, 35. But when you are my age, try to do not come down with influenza. The same thing holds true with COVID. If you want to get COVID, get it when you are 20. But when you are age 75, obviously the mortality severity of the virus is going to be substantial. And also the virus is going to be very fatal in pregnant women. Not only influenza, not only COVID, all of the viruses, hepatitis A virus, hepatitis E virus, you're going to have significant impact on pregnant women because pregnant woman is immunodeficient. And then neurological disease, and then I told you about cardiovascular complication. This this virus would give you myocarditis, would give you arthritis. So imagine somebody already has coronary artery disease. Now is coming down with myocarditis. Is coming down with the coronary artery angiitis. So obviously that person is going to die very quick. And this is the rheumatological manifestation of the virus. So those of you who are familiar with the clinical manifestation of rheumatoid arthritis, a small, basically joints of the hands, this is not really much different from a rheumatoid arthritis. 43% of the people who come down with this infection, uh, they are going to have some lingering clinical manifestation, even beyond 3 months. And then, uh, particularly if the person is older than 45, if the acute illness is very severe, or the person has comorbidity, then the chronicity of the infection is going to be more among this group of the people. And what is the reason behind chronicity? Is persistence of the virus or some part of the antigenic debris of this virus in the joint and tissues. And this is going to trigger persistent immune system. So the immune system is going to target the place that has trace of the virus. And we believe mainly the joint is going to carry debris of the virus. So the body immunity mainly is going to target the joints. But mortality overall is less than 1%, but maybe higher, even higher than 10% if the person is going to have comorbidities. People with diabetes mellitus, people with cardiac neurological involvement, obviously they are going to have a poor prognosis. Or even the people who are co-infected with another virus, they might have even higher uh, mortality and severe form of the disease. So the disease is bad, no question on that. So how we can prevent it? So vector control is not easy. You know, we have failed vector control. We are trying getting poison, any insecticide, the new generation of the insect, they become resistant to it. Forget about the fact that we are going to pour poisons to the environment and we are going to have significant impact on ecosystem of the environment. But these are living cells, living creatures. They go through point mutation, and then finally, one point mutation is going to make them resistant to uh, to the poison or insecticide that we use. You need to prevent mosquito bites, and obviously, prevention of mosquito bites, we are very successful on that because we have DEET, for instance, or you can use all the time long sleeves, for instance. Don't expose your skin to the mosquitoes. And fortunately, now we have the successful vaccine. So this is the first one. This is the uh, attenuated. A stands for the attenuated. Virus is obviously alive, but attenuated. VAL, so means the virus, this is a vaccine that we try to capture the virus, manipulate the genomes of the virus, and then make it livable as it is alive, but is not pathogenic anymore. So this is the first one, VLA1553. This is the vaccine. So they grab one of the genotype of the virus. They deleted 61 amino acids from the wild virus and they make it a weak but living virus, attenuated virus. It was licensed in the United States in November of 2023 for prevention of the disease caused by chikungunya virus in individuals 18 years of age and older who are at increased risk of exposure to this virus. So later on, I need really to define for you what I mean by basically in who is at increased risk of exposure. And shortly after, European Commission also granted marketing authorization of this uh, vaccine. And what is the efficacy of VLA 1553 vaccine? So this is the phase 3 trial of the data. And I want you to focus first on uh, people, on the individuals who were young, 18 to 64. So you see that we have two groups of the enrollees. One are younger and one obviously older. And you need to remember, anytime that we want to make a vaccine, we have to all the time show the efficacy of the vaccine on old people as well. So this is two group, and then they received the vaccine, and this is placebo. So the group, 73 of them, they didn't receive the vaccine. They received probably, saline injection. And then you would see what is the primary outcome, what they were looking for. And this is very important for you to know. This is not efficacy study. This is not the fact that giving me the vaccine, sending me to Dominica and see if I do come down with the virus, chikungunya virus or not. You're looking only for the immunogenicity biomarker. You're looking for IgG, IgM level in the serum. So they inject the attenuated virus into my arm, and then they are going to measure the serum level of the antibody that my body is going to make against the virus. But you can all the time argue that this is not a good study. This is a great study at this point, but finally we need to go through efficacy study. On the other hand, we need really to come, for instance, to Dominica and then give this vaccine to the people and then see what would happen to the people who receive this vaccine and to the people who do not receive the vaccine. How many percent of each of these two arms they did come down with chikungunya virus? That would be the ideal form. That's something that we did, for instance, for SARS-CoV-2. But here they look only and only for the antibody against the virus. So obviously, saline injection did not produce any antibody against the virus. So 0 of 73, the antibody level against this virus was none. But then you would see 98.6% of the people, or 98.6% of those of 207 individuals who received the vaccine, they produce antibody against the virus. And now, if you focus on older people, 65-year-old or older, then you would see they also had phenomenon, basically, immunogenicity. So the serum level, they seroconvert. Seroconversion in both young and old was almost the same. So phase 3 trial data released to neutralizing antibodies rather than protective efficacy. So they did not check the protection and the immune response in adults more than 65 years was particularly examined due to increased risk of severe disease in this group. And there were no differences based on sex, body mass index, ethnicity, or race. And this is a Kaplan-Meier curve. And if you look at the two curve, you can see they are almost identical. So this means that the injection, the vaccine was successful both in young population as well as old population. And what about the safety of this vaccine? There was no significant safety concern, and many of the patients that did have mild or moderate side effects. Most commonly was headache, fatigue, myalgia, fever, and nausea. And this is also true when you go and get your flu vaccine. This is also holds true when you go and get your COVID-19 vaccine. So because this is live attenuated vaccine, obviously you cannot give it to any person who is immunocompromised. So if there is somebody who is pregnant, for instance, you cannot give live attenuated vaccine to a pregnant woman. You can give it to somebody who has HIV with CD4 cell of 50. You can give it to somebody who is HIV and the CD4 cell is 500. But if somebody has HIV and the CD4 cell is extremely low, so this means the person is immunodeficient. So if you give a live attenuated virus, this attenuated virus is enough strong for immunocompromised person to invade the body of that person. But unfortunately, if you look at the side effects of this, you would see that 11% of the vaccinated individuals, they did come down with arthralgia, and 5% of them, the arthralgia arthritis was severe. So one of the side effects of this vaccine, unfortunately, as we are speaking, is severe arthralgia. Now coming to another vaccine, which is soon is going to be approved, and this is the lipoprotein part of the virus. So is not the virus, it is not attenuated virus. It is basically some glycoproteins of the virus. They use that glycoprotein as antigen, and the body is going to make antibody against that glycoprotein. So is lipoprotein part of the vaccine? Do you know one vaccine that we use the lipoproteins as the ingredient of that vaccine? Influenza. Influenza is not live attenuated. It is basically a part of the or different part of the virus. So is lipoprotein, glycoprotein, adjuvant, something of that kind. So influenza virus. But do you know live attenuated virus vaccine? Do you know any of the vaccine is live attenuated virus? Measles. Measles vaccine that you use is live attenuated virus, basically. Also, uh, for instance, we do have two forms of vaccines in uh, in block the name in a small pox. Wonderful. Polio, you're right. One of the two forms of the vaccine that we have for polio is the ingredients of the virus. But we do have also another form of the vaccine for polio, which is the live attenuated. That's the one that we give the person to eat to as a drop. But the one that we inject is the lipoglycoprotein of the virus. So this VLP is a virus-like particle vaccine, and mainly from envelope 1, envelope 2, and C proteins. And it was extracted from the Senegal West African strain. These are the details. It's not really necessary, but I want just to show you the data. that also when they look into the antibody production against the virus, it was very successful, both for people who were young and those who were old. So we do have now some efficacy study in both of them, but it has not been published yet. But so far, everything that we have in literature is about the phase 3 trial of this group of the vaccines. And if you look at the Kaplan-Meier curve, you will see it is also has the same efficacy in different age group. And what about the safety of this vaccine? It is extremely safe, and there is no evidence of chikungunya-like symptoms after vaccination or of severe arthralgia and arthritis. I would bet that this is going to be the vaccine that would be acceptable by most of the people. You can give it to immunocompromised hosts because this is not live attenuated virus vaccine. You can give it to pregnant women. You can give it to everyone that you wish. And also, you shouldn't be worried about significant consequences of the vaccine. But you need to remember that we do not have very long-term follow-up on any of these two vaccines as we are speaking. I particularly focusing on the vaccine because I would stop soon and I want really you tell me your concern about different vaccines and your reaction, for instance, to this discussion and having a dialogue. By that dialogue, I'm going to learn more from you, and hopefully, I can contribute also to the discussion. And how can the data on both vaccine be compared? Obviously, both of them are good. Both of them, they have the same efficacy when you look at biomarkers at immunogenicity. And I'm going to skip this slide because this is the vaccine recommendation in Europe, but I'm going to mainly focus on what are the chikungunya vaccine recommendation in United States. And uh, the one that I'm going to focus is basically anyone who is going to go to any community that there is a report of this virus, not the outbreak. For instance, in Dominica, if you think there has been sporadic cases of the chikungunya and you are going to stay in this island for more than 6 months, cumulative. For instance, over 1 year, you may come here 3 times. And when you come to this, basically each time you're going to stay for 2 months. So cumulative time over 1 year is going to be 6 months. You are going to be eligible to receive this vaccine. There are obviously travelers that they need, if they go to Brazil during one of the outbreak, definitely they need to receive the vaccine during the big outbreaks. The old people, particularly because they are very much prone to the severe form of this virus, obviously they need to learn that the vaccine is available. So closing remark, chikungunya disease is becoming more widespread. It is already in the United States and is moving up the north. It is already in Europe, but has not maintained itself. It can cause serious complications and even death. Less than 1% if you are healthy otherwise, more than 10% if you have comorbidities. Vaccines are a recent addition to prevention of this virus. We have a live attenuated vaccine, which has been approved by European as well as United States. And VLP vaccine is in very late stage clinical trials. And I have learned from people in CDC, FDA that by the July, most likely they have enough data to approve it. Surveillance is the key to detect the outbreaks, but unfortunately, we do not have the surveillance system in place. We do not have even diagnostic kit for diagnosis of the chikungunya in most of the resource limiting countries. And obviously, in certain places that we have a large number of the doctors and nurses and social workers, collaboration between them in management of vaccine delivery and prevention of this virus is crucial. I would stop here and take some questions before I present to you some questions to for discussion.
Please, my concern is about the vaccines. The difference between the live and the I'll say the dead vaccines or the weak vaccines, because most of the time people's concerns are for the live vaccines. Just a single dose will work and it works faster. That one, like the immune response is quick, is very fast. But for instance, for this vaccine, the VLP vaccine type, most of the time it needs booster. You don't get an immediate response. So looking at this case, um, what will be your input about this for someone who wants to we want to educate on vaccines? So how are you going to convince such a person to choose between life and the I would say the weak or the dead attenuated vaccines?
Fantastic question. Thank you very much. So, is the benefits and harms of the live attenuated virus vaccine versus the glycoprotein, lipoprotein type of the vaccines? In 2025, you're shy away by using the live attenuated vaccines. And the reason, because in United States, we have almost 10 million people who are immunocompromised. You're on chemotherapy, you're on radiation therapy, they have HIV, and your bone marrow transplants, your organ transplants, solid transplants. So 10 million of the people of United States, you're immunocompromised. Then imagine add to the immunocompromised 10 millions of the immunocompromised people in the United States, the number of the pregnant women. And then add to that the population of the people in the United States who are 65 or more. Because aging is going to brush up your immunity gradually. And now we have so much of the basic science on that. Why the CD8 is going to decline, why the CD4 is going to decline. But people who are age 65, don't look at them that they look good. They're immunocompromised. Not anatomically, they are immunocompromised. They are really immunocompromised. They do not have enough of the cell mediated immunity to fight against the viruses. So we try to be shy away of using live attenuated vaccines. So we moved toward glycoprotein vaccines, which is difficult to make a mass vaccination because making all of those components needs a system and it's slow. Imagine for, I'm just make an example, for instance, influenza vaccine before the new technology We need to grab so many eggs and would take 6 months for making them attenuated and then kill them or take some part of that. But now we move toward the messenger RNA vaccines. What we mean by messenger RNA vaccine, so you know that you are interested in lipoprotein A, for instance, because you learned that lipoprotein A is very immunogenic. If you give me lipoprotein A of Chikungunya virus, then you can see significant amount of the antibody against this epitope. So I'm going to make the frame or that template of the nucleotides that you're going to make that a specific protein. And then I inject that messenger RNA in the body. So messenger RNA is only carrier of the code. And this is going to get into a certain number of the cells and it's going to go to the Golgi body and it's going to start making the lipoprotein or protein that I am interested. So making that epitope now, it is very easy. That's the reason by messenger RNA, if I know about a new virus today, in a month, I can make a vaccine for that virus. It's a significant progress in the technology of the vaccines. Or sometimes I use another virus as a carrier. I would explain to you what I mean. For instance, if I know there is a virus, adenovirus, and all of us, we get adenoviruses. And I know the adenovirus is benign virus. I get the adenovirus. And then I go into the genetic code of the adenovirus. And I steal a piece of the gene from the adenovirus. And then I put the genetic repeats of the nucleotides of my interest in that piece. Then adenovirus is going to have the codes to transcribe later on the antigen that I am interested to produce. But then I'm going to inject into the arm of you, myself, chimp adenovirus or human adenovirus that I know is benign virus, but that virus is carrier for a part of the genetic material of another virus that I'm interested in. So then the body is going to start proliferate that adenovirus. And as the adenovirus is going to go through multiplication in the body of the human, is going to produce that antigen. And then the body is going to recognize that antigen and is going to make antibody or cellular immunity against that antigen. Both of those technologies were very successful in SARS-CoV-2. So SARS-CoV-2 basically immediately opened a new technology to the vaccinology. What was very expensive, trillions of the dollars went into that industry. And then now we have the technology of the messenger RNA vaccine. But the bottom line is production of the lipoprotein or another type of the protein of the interest in a short time and during particularly unprecedented or unexpected outbreak. It is very handy. Easily you can sequence the new virus, and as soon as you know the sequence of the virus, you as a scientist, you can open the gene and then you will say, oh, this part is very important part. Then you are going to try it in human, in ZY, and then you know this is immunogenic. Then you are going to have the messenger RNA, and then you are going to inject into the arms of the millions. Then you have to wait. Obviously, you go through trials, phase 1, phase 2, phase 3 trials. And then finally, phase 4 of the trial that is going to be given to the people, and you're going to follow them for a long period of time. And here is something that I want to mention because during the COVID-19, in a matter of fact, many of the people who were against vaccination, obviously, all of us, we should be worried about the vaccines because this is something somebody puts into my arm and I don't know exactly what is going to happen. No question on it. And the CDC and the FDA were very careful on that. And they request the people who are received the vaccine report any side effects. So I am a father of a child, took my child to a clinic, and that child received the vaccine, messenger RNA for COVID 19. And I was driving home, car accident, the child dies. The parent is supposed to call the CDC and say, my child died after vaccination. And now it goes into a data source, which is open to the public. It doesn't mean that a child died from a vaccine, but CDC wants to be sensitive toward any side effects. But one day somebody is going to open that file, is going to review the exact cause of the death of the child, and then will say this was not related to the vaccine. During pandemic of the COVID, many of the people had access to these basically information, and they start talking about the side effects reported to the CDC, not approved by CDC. And suddenly everything happened. Yes, I received vaccine, and then I came down with acute myocardial infarction. I received vaccine, I have the stroke, for instance. But now when we have billions of the people receive the vaccines, and we have very robust way to analyze the data, we know what are the side effects of that vaccine. I would give you another example, like you know, like polio, because we have two different types of vaccine for polio, and they have been in the market for a long period of time. So we know exactly the side effects of that vaccine. This is not something just the vaccine came out, but we know that inactivated polio vaccine is better than oral formulation, which is the live attenuated vaccine. Live attenuated vaccine, if you look at the genome, one end has a cup, and this cup has been modified. So the attenuated virus can marry another enterovirus, because the poliovirus is enterovirus, and is going to steal the cap from another enterovirus and put it on the head, and then becomes Y. And then that oral vaccine, unfortunately, is going to be shed in the community, and those who are susceptible, they are going to come down with the polio. 8 people in United States used to come down with this form when we were using the polio, but there was compensation for that. We knew that 7, 8 people, they come down with the reverse of the attenuated virus to the wild form, and they come down with the polio virus or polio, and government would compensate those 6 or 7. But then finally we said no. In 2000, we said we are not going to use the oral polio vaccine anymore, and now we are using the inactivated. But oral polio vaccine is a success. When you go to Afghanistan, you go to Iran, you go to another country, it is easy to go to door, and then ask the child, open the mouth, and then put a drop of the vaccine in the mouth of the child. But imagine if you want to do it with injections. There is no enough resources. I wish that we could give inactivated vaccine to everyone. It doesn't matter where, but it's not practical. Very recently, we did have in Tanzania an outbreak of the polio. One person from Pakistan flew to Tanzania, and then obviously the reason was basically this oral polio vaccine. It was not the wild form of the virus. So uh, it was very long answer to your fantastic question, that live attenuated, uh, we are trying to be shy away from that, but still we have historic, very successful vaccines, like measles vaccine, for instance. And the newer one, it was the chicken pox. But now, obviously, for shingle, We had live attenuated, but now obviously we abandoned that because now we have the lipoprotein type of the vaccine for the shingle. So we are using that. But overall, when you give a new vaccine to any community, you need to follow them for a long period of time. And I told you when I was presenting this data that these are the biomarkers, zero marker, and zero marker is not yet. We don't know what that means when we are going to study this group of the people on efficacy of the. And then for the side effect, you need to have short-term follow up and then obviously long term follow up. And then based on that, then you can talk to the public and educate the public about the side effect of each of the vaccines. I want also to make a final comment on this one. There is not no intervention that doesn't have a side effect. When you are giving something to the people, you need to know what is the benefit and what is the harm. And this is important for you as medical student to remember. Even if you give me aspirin, if you give me Inderal, if you give me beta blocker, you give me any antibiotic, there is benefit and there is going to be side effect. And you need all the time to say, okay, which is more? And if the benefit is more than the harm, then you prescribe that for me. But you're going to educate. For instance, during the messenger RNA vaccine, we learned that if you give it to very young men, like 17, 18, or they would come down with myocarditis. So one of the side effects of the vaccine was myocarditis. But then we learn if the person is acquiring the SARS, the chance of the myocarditis during the natural course of the SARS-CoV-2 is 10 times more than the vaccine chance of the myocarditis. So I have a patient who is 16 or 17, not a patient, individual who comes to my clinic for the vaccine. I would say, listen, you are young, you are a man. If I give you messenger RNA, Moderna vaccine, your chance is going to be 1 out of 56,000 that you are going to come down with myocarditis, and myocarditis is going to be benign. Nobody, as we are speaking, has died of the myocarditis from the vaccine of the SARS-CoV-2. But if you are coming down naturally with the virus, your chance is going to be 10 times more and you may die. Now is choice. The individual can really say, okay, should I do or should I not? So you need only educate your patients, be very, very, listen to the concern of your patients, because many of the patients, when they have concern about the vaccines, they have very good questions. They are worried. They are mother and the father of a child, or they are concerned about their parents. They are concerned about themselves. You have to have the literature and tell them what we know about that vaccine at that point of time. Any other
Yeah,
questions from this side?
yeah. I had a
Yes.
question. Regarding what you were saying about in Brazil, the outbreaks are sporadic and large versus in India them being endemic. So I wanted to know um what are the factors that are contributing to it being endemic in India? Is that something that could replicate in other regions, or is there just something unique about particular areas that allows the disease to
Okay, you
perpetuate?
have to help me with one more time to understand the question. Sorry, it's me, not you.
Okay.
Okay.
So, in regards to what you were saying before about the outbreaks in Brazil being sporadic versus in India they're endemic, so I'm asking, what are the factors that are contributing to that? Can
Okay.
other regions become endemic as
Yes.
well, or
Fantastic.
how? Yeah.
Thank you. So the question is why the outbreaks in one part of the world is so different from another part of the world. Why, for instance, in Brazil, we have small outbreaks and then we have larger outbreaks, but there are period of the time But practically speaking, there is no any chikungunya virus. So it comes and then goes away, and then it comes. It may be a small outbreak. It could be big outbreak, but there are times, weeks, that there is no any report of the virus. And then this, the India, it is all the time sort of the ongoing but low number of the patient with chikungunya. But why the reason? What is this one? The virus is the same. Mosquitoes are the same. Is more of the human behaviors. But if you ask me the details, what the people in Brazil doing that makes them different from the people in India, I don't know. Whether they use, for instance, more of the screens during certain seasons, I have no idea. But we know that the outbreaks in different parts of the world is not the same with this virus. Any? Yes, please. Thank you. So the question is basically, so the data that I presented to you only showed the antibody. What about if somebody is going to come down with the natural form of the wild virus, whether that person is going to have the immunity or not? Obviously, natural immunity is lifelong immunity, as we know, because we know this virus for, imagine, 15 years. So the people who have acquired the virus, so far, they have not come with the second, basically, attack of the virus. So the natural immunity is solid immunity. But the vaccine, still we don't know. The vaccine, we know that is causing a lot of really antibody. But as you know, in virology, particularly when you have immunity against the viruses, you have two different type of the immunity against the viruses. One is going to be cells that becomes the basically producer of the antibodies. They mature into plasma cells, and the plasma cells is going to give you IgG, IgM, IgD, and etc. That's when the virus comes to the body, and the body catch the virus immediately, but cannot really kill all of the viruses. So the viruses are going to escape, and now we are at the mercy of the those cells that we are going to recognize the part of the epitopes of the virus, and this is the monocytes. In a matter of fact, the monocyte defense line in viruses is 100 times more important than the antibody generation against the viruses. Unfortunately, studying the monocytes is extremely hard. This is the reason most of the data, when they want to come to the efficacy of the vaccine in the phase one, phase two, and even phase three sometimes, they use some biomarkers that are easy to measure. That's the reason they go for the antibodies, because serum, you take the serum and then you check for IgG or IgM. But now you want to check the monocytes and then see how monocytes are fighting off the virus. That needs, in United States, we have only probably 3, 4 labs in the entire country that are very good on studying the monocytes and their defense against different sorts of the epitopes. Question from my, I'm sorry, oh, surveillance, you mean? I, Different countries, obviously, they have different approaches. I do not know really there is anything in Dominica, for instance. But as I told you, there is an organization, for instance, organization that CDC is collaborates with, and they have put more than I think 400 clinics around the world for returning travelers from different parts of the world, and they have the most sophisticated lab. And I highly encourage one of you to reach out to them and make them to come and establish one of these centers in Dominica. Also, so when the group of the people come to them, and it's also migrants, so they accept the migrants and they accept also travelers. That's one way of the surveillance, which is first step toward a good surveillance. The good surveillance you have in each corner of the world, in each village, you are going to have a lab sophisticated with PCR multiplex. Then the patient comes, or doesn't matter, is local or is a traveler or is a patient with fever. You're going to get the blood, you're going to put it in one drop in that machine, and the machine is going even to identify a virus that never ever been discovered before. This is the way that we go now in United States. In United States, for instance, now we are not going to use microbiology, for instance, to culture E. coli or culture, or even, for instance, check for the antigen of the virus in the upper airway. You go to Yale, for instance, clinic to emergency department. You have this is the summertime. I'm sorry, the winter time, and you have cough and you have basically sore throat. They swab it, they send it for the PCR, and we have three different type of the PCR complex, and one of them can identify 21 viruses. Metapneumovirus. If this is the cytomegalovirus, if this is this virus, easy can it can do it in less than 20, 30 minutes. But I want just to let you know that surveillance is so important, but is lack in our system. Do you know how we learn about the Ebola virus in West Africa? I just want to make you a big example. In the West Africa, we never had the Ebola virus before 2014, 2015. We never even knew that the virus is going to get so far to the West Africa. We knew about the Ebola virus in central part, in the eastern part of the Africa, in Congo, or in Tanzania, in Uganda, for instance, but never West Africa, never ever. So the virus moved to that part, and this is a small village. And a boy comes down, 2-year-old boy comes down with explosive diarrhea. The boy was taken to a small clinic, but imagine I'm talking about a village in Guinea. So imagine a village here right now, and then go when I say clinic, practically speaking, I mean probably a small cottage, something, and and the child has diarrhea, and obviously would receive something, and then the child dies. The mother is pregnant, and the mother acquired the virus. The mother dies, the baby dies. They have old sister, 9-year old, and now she's sick. And grandmother comes from another town, and grandmother comes to this village, and the grandmother is one of the local healer. That this grandchild or granddaughter dies. Now the grandmother is sick and goes to another town, spread the virus to another town. Now many of the people come down with diarrhea. In Ebola, we were thinking all the time that this is hemorrhagic fever, nose bleeding, GI bleeding, but this time it turned to be like cholera. Now we have 64 patients, they have diarrhea. One day, one of the physicians grabbed the phone and talks to a friend in Belgium and would say, listen, I have a group of the patients with diarrhea, and I give them doxycycline. It looks like cholera. I give them hydration, but why? But they have very high fever because cholera never gives you fever, but they do have fever, and then they die. And meanwhile, on the phone, he said they have hiccups. And then he said, "What? You said hiccup?" He said, "Yeah, they have hiccup." He said, "Listen, I was in Congo and I was one of the members of these basically Doctors Without Border, and I have taken care of many patients with Ebola in Congo. Hiccups, send blood to the CDC for Ebola." That was when we learned that we have Ebola in the west part of Africa. No surveillance. If it was surveillance, we would never have 12,000 of the people in West Africa died. 12,000. 30,000 of the people that came down with the Ebola virus. All that I want to say that I wish that we had a good system, a good surveillance system in place all over the world. That was ambitious goal during the COVID-19 because they were thinking that now is the time, but I do not think really even right now we have energy or anyone at the White House or anyone in the CDC is going to have any motivation, for instance, to put, for instance, a surveillance lab in Dominica. But you people need really to do something. As I said again, reaching out to Geo Sentinel Group and asking them to establish a clinic here. That would be, they are interested. I have no question in my mind they would be interested if you have a manpower who say, listen, I'm going to put them in the clinic and this is what I'm going to do. And probably you're going to support you with the lab and other equipments. Okay. So any other questions from this side? Oh, oh. Okay, people. Thank you really very, very much for lovely discussion. And tomorrow I'm going to talk about sexually transmittable diseases. And I know that sexually transmittable diseases are, basically needs a course, but I'm going to talk about the only herpes viruses because I talk a lot about the RNA viruses. So I thought today I'm going to introduce to you a DNA virus, and the DNA virus, obviously, herpes is going to be one of them. And obviously, is something that I'm sure all of you have so many questions about the, marriage, somebody has positive, negative, Z, Y, pregnancy, consequences. So I thought today I'm going to only focus on the DNA virus, and prototype of the DNA virus is herpes viruses. Thank you very much.